Hey there, welcome to Gals Get Real, where real women, real stories, and real talk come together. I'm Meghan.
I'm Kristin. Between us, we have 9 adult children with 6 daughters. Let's open up the conversations we never had with our moms and flip the script with the kind of connections we want with each other and our daughters.
We're here to laugh, cry, and dive into all the things, from everyday shifts to the curveballs and life pivots, and the messy, magical moments that make us who we are.
Meghan, we are so lucky to have our guest today. We have Dr. Shieva Ghofrani, who has been an OB-GYN in private practice since 1999 in Connecticut. She has had her own personal journey through pregnancy loss, HPV, weight, endometriosis, and then ovarian cancer at age 46. Shieva uses social media to help further engage and educate women, thank goodness, on their OB-GYN health, and recently started a private telehealth practice as a midlife strategist. So fantastic.
Amazing.
Hi, Shieva. Welcome.
Hi, ladies. Thank you. I love being with you guys.
We love it too.
We love it. So thank you. So we know that you, from the introduction and from knowing you, are an ovarian cancer survivor. So would you like to tell us just a little bit sort of about your diagnosis, your journey, and sort of all the things you went through getting to this point?
Yes, I would love to tell you. And I'm going to weave in a little bit of teaching about ovarian cancer, because I think that the worst part about ovarian cancer is that it's very poorly understood by women and by doctors often. And so it gets this label you might have heard of called the silent killer. Have you heard that term?
Yes.
I have heard that term for ovarian cancer and for pancreatic cancer, because there is literally no screening. Am I correct in saying that?
You are correct. There is no screening test, which means just that there's no test where you would go into your doctor once every year or 5 years or 3 years, depending on no symptoms, and the doctor could do a test, meaning the cervical cancer test would be the pap smear. It's once every 1 to 5 years. Colon cancer screening would be once every, again, 1 to 10 years. Breast cancer screening would be a mammogram once a year. Those are all screening, meaning you go in with no symptoms, they do a test, and then they can tell you what the risk is, right? We don't have that for ovarian cancer or pancreatic cancer because those organs are deep inside and hard to reach. We can't squeeze them easily. We can't swab them like a pap smear. And we can't just do ultrasounds for a host of reasons we can get into later. The problem I have with people saying silent killer is that neither of them is actually silent. And that really disempowers us and makes us think, well, there's nothing we can do. Just throw up your hands. There's no test. There's no nothing. You're just going to wake up one day with stage 4 ovarian cancer and die. And that's not true. So what we need to do better is educate on the fact that there's no screening test so that women don't think that when they get their pap smear that they're actually screened for ovarian cancer, because they're not.
I think that's a really key point.
Right? People think, because I have my own best friends will sometimes be like, wait, how did you find it again? Was it your pap smear? No. And these are educated women who are with me through the diagnosis. So we first need to know that you can't get screened for it. But second, we need to really teach that all is not lost. It's not silent. It is subtle. Meaning, if you have certain symptoms, you need to know that they're likely not ovarian cancer, but you need to go to the doctor and perform certain tests. So we'll talk about that after, but that's the framework. And I say that because I actually often say I don't like to be considered a survivor, not because I take offense to it, but because I don't feel like I was plucked away from the precipice of death, right? I don't feel like, oh my gosh, this was so dire. And I say that again because I think there's a lot of fear around cancers, right? So the minute someone hears ovarian cancer or any cancer, they assume they were one step away from death. And that makes it very dramatic. And that like fear invoking in our body, I think really triggers more hormone changes and cortisol changes, things that are just not good. So I always say I wasn't stage 3 or 4 even. I was stage 2, which in the ovarian cancer world is very early because 2/3 of women are found at stage 3 or 4. So why I'm here to talk about it all the time is because I want more people to be found at stage 1 or 2, where the odds of survival are much, much, much greater. So that's why I always say I'm not offended when someone calls me a survivor, but I don't feel or refer to myself as a survivor. And it's very specifically because I don't want to keep creating that fear narrative that women tend to have.
No, I think that's so true. I mean, totally different. But my mom had a brain aneurysm when I was 21. She was
Mhm.
47, and I found her. And she did survive. She was never quite the same. My dad had cancer. And it's one of those things when you have sort of a cancer diagnosis or even a traumatic sort of health scare, even if the outcome is good, it invokes a real fear in you and sort of created a real
Right.
sort of hypochondriasis in my world where
Yeah.
everything became about health and me.
Right. Well, and it sounds like in your mom's case, she really did like survive something very, very dramatic, right? And that's not to say that my ovarian cancer was not. There were complications. It was dramatic. But again, my diagnosis at stage 2, by definition, meant my survival rate, my 5-year survival, which is typically
Was
how we
much
measure,
higher.
was like 80 to 90%.
And what is it out of curiosity if it's stage 3 or 4, or does it depend?
It depends, but it depends on a few factors. And the survival rate's going up from when I started 26 years ago to now. We have more and more chemotherapies and different treatments, but it's still like 30-ish, at most 50% if you get to stage 3 or 4.
And that's a huge differential.
It's a huge difference. And also, if you're surviving, you're usually going through multiple rounds of chemo and recurrences. And so your survival also looks different. So again, that's why I kind of say, like, I wasn't a survivor in that traditional
Gotcha.
sense.
Okay.
And my type of ovarian cancer actually came from endometriosis, which is not very common. So again, to not fearmonger, I want millions of women to know that even if they have endometriosis, the odds of them developing ovarian cancer is small. So it's not high, but it is there. And a lot of people don't realize that either. So my story was basically that I grew up like many women having terrible periods. But what are we taught? Like, suck it up, honey. It's just your period. So whether you're lying in a fetal position every month, periods are hard, right? This is what we are all taught as a narrative as
Definitely.
women to this day. And that is another part that we could really address. So I sucked it up, and it was I had terrible periods. And then come to find out when I was 28 years old that I had endometriosis in my ovary, which was 17 centimeters, which is like, for anyone listening, I'm holding up my hands. It's like the size of a huge grapefruit, 17
Yeah.
centimeters
And
in my
what size
ovary.
should it be?
Oh, your ovary should be 2 to 4 centimeters.
Oh, wow.
Wow.
So it was this big, literally this big. And it was in my ovary, and it kind of explained all of my pain. I had surgery to have that part of my ovary removed. And then my periods were really fine for years because I was then on birth control, or I was pregnant, or I was miscarrying. Rarely I was lactating because I wasn't very good at that. But all those things suppressed ovulation. And so my endometriosis was largely controlled until my early 40s. I was done having babies. I had had my tubes cut, not removed. And I'll talk about why I say that later. So I didn't need birth control. And my periods were fine for a couple of years until at age 45, they started coming back with a vengeance, like really intense. But I did to myself what many patients do to themselves, or what doctors do to patients, which is I said to myself, okay, it can't be anything bad. It's just my endometriosis. I know what this is, because in between, I'm operating, I'm like staying up all night working, I'm with my kids, I'm fine. I just need like bottles of Advil during my period. And so it's just endometriosis. And the truth is, I was correct. It was endometriosis, but rarely it can transform malignantly into ovarian cancer. So I treated myself kind of like I would treat any patient in a good way, meaning I got a pelvic ultrasound in my own office. And my ultrasonographer, who's amazing and so astute, said, I know that you would tell your patients with this 4 centimeter abnormal looking cyst that you should get an MRI. And I was like, okay, I'll get an MRI just to put my money where my mouth is. But we know this is an endometrioma. We know what this is. I don't really need the MRI. But I said, I'll do it, even though I had to pay $2,000 or $3,000 because I had a deductible. And I said, I'm only doing it just to prove to everyone else that I did it myself, right?
And you
Lo and
really,
behold-
in your heart of hearts, believed that there was no shot it was going to be anything more
not
than
even a question.
endometriosis.
To the point where when the radiologist called me to say, by the way, this looks irregular, I said to him, oh, you guys tend to overcall these. It's an endometrioma. I'm going to get it removed because I'm in so much pain, but it's going to be benign. Even my GYN oncology surgeon, who's amazing, so well trained. I mean, she was literally top notch, who I'd known for years. She had trained us. She agreed with me that because of certain parameters, the odds of it being malignant were very small. Now, here's the really important part. Even though the odds were small, it wasn't zero. So I did what I would make any patient do. It's likely nothing, meaning nothing dangerous. But first of all, you're in pain. Second of all, we don't know it's nothing. The only way to know is to remove the ovary. We don't do a biopsy on an ovary the way we can biopsy the cervix, the colon, the breast, because if we kind of go in laparoscopically and remove a piece of it, we risk it spreading. So in order to know if an ovary is abnormal.
Very interesting.
Yeah.
Okay.
You could sometimes remove a cyst, but it's not like what you do with a mammogram where you just go in and like take a little piece. So in my case, I was 46. I didn't need the ovary anymore. The plan was go in, take out your ovary, send it to the lab. If anything else looks abnormal, she'll take everything else out at the time. I woke up from that surgery and she was hovering over me in the recovery room. And she said, so it turns out it was a borderline cancer, which means just about to turn into what we call invasive cancer. But I removed everything. You're going to be fine. I was like, great. Unfortunately, a week later, the final pathology came back that it actually was a stage 2. Do you know what's so funny? I always say stage 2C, but I just found my operative report. It was actually a stage 2B, which just differentiates a little bit like how progressive it had been. Stage 2B ovarian cancer. And so that launched me into making sure that I was getting the right treatment, finding out what chemotherapy I needed.
Not to interrupt, but hypothetically,
Yeah.
how quickly is ovarian cancer generally a relatively quick growth? So
Yes.
would it have been
Yes.
6 months, a year, potentially, that it would have gone to a 3 or 4?
Oh, yeah. Meaning,
Or
okay,
months?
so then again, mine was an unusual type. Mine is a more rare subtype, but actually confers slightly better prognosis because it grows a little more slowly
Okay.
because it really is endometriosis in the ovary that malignantly transforms. So mine might have taken 1 or 2
Okay.
years to
But
progress
it's
even
relatively
further.
quick.
But typical ovarian cancer is much quicker, which is one of the reasons we don't have a screening test for it. Because unlike, again, a mammogram where we can say, okay, most patients, if we check yearly, we'll be able to see what's happening. If I did an ultrasound on both of you and I see that your ovaries look normal, there is no good defined interval with which I can say, oh, guys, you're totally fine. You just had a normal ultrasound 6 weeks ago. Because even within 6 weeks, our ovaries can change. And so that's the
Wow.
problem.
That is
Ovaries,
really. So,
Yeah.
given that timeline, what's the recommend to women to just pay close attention to our bodies, our symptoms, and respond in a timely manner?
Yes. And so what that means is, again, first, understand and know the facts that you do not have a screening test. And that's important, not so that you're like, oh my God, that sucks, this is terrible, but so that you're not misled into thinking, hey, left my gynecologist again, everything was fine. That means I have nothing wrong. When you go to your gynecologist, you're getting typically a breast exam, you're getting maybe your pap smear if you're due for it, you're getting someone to look at your vulva, you're getting a pelvic exam where we feel around, but that's not saying there's no problem. That's essentially objectively saying, at best, I checked for breast cancer, your screening test was normal. I looked at your vulva, I didn't see anything abnormal. I did your pap smear, you don't have any sign of HPV with signs of cervical cancer. And then I felt around, so there was no huge mass in your pelvis. But even just feeling around the pelvic exam portion where we do what's called a bimanual exam, I'm making this gesture because you guys probably know we put one hand inside and put the other hand outside.
Yeah, thank you very much for that.
You know, that's like the mind.
The highlight of our day always.
Yeah, that pelvic exam, it's really also important to know, is very, very not sensitive, meaning not that it's an emotionally insensitive exam, which it is, but it's that it's not a sensitive test in the screening test world. We can have masses that are very large that cannot be palpated or felt by the clinician, not because the clinician's bad, but because of how our pelvis is. So we can think about it, I had a 17 centimeter mass growing in my pelvis. By that point, the doctor who examined me felt it, but only after I went to them. Had I just gone to them even a month prior, they might not have been able to feel it because it might have been only 12 or 13 centimeters where they might not have felt it. So again, first know what you're screened for. Second, you have to know the signs and symptoms. And there's a variety of signs and symptoms, but most women, when they do multiple data points and they do all these surveys, most women present 6 to 8 months after already having persistent bloating, persistent pain, persistent feeling pressure in their pelvis, any one of those, not necessarily all of them. And if you asked me, I would have been like, oh yeah, I was having pain every month, right? Or when I had the 17 centimeter one, I looked back and thought, you know what? I have been feeling a lot more pressure to pee because that big thing was sitting on my bladder, but I ignored it. So the problem with us as women is that we tend to ignore it because the messaging from the patriarchy, right, is like, you're fine, you're fine, you're fine. So we ignore it. Plus, we're all busy. We're either like, we're mothers, we're daughters, we're sisters, we're working. We also have changes in our body, especially if we're premenopausal, where we're cycling every month. So any given day, you're going to have certain symptoms. So it's all very confusing. So what I try to say to patients is, let's be calm about this. If you have bloating or pain or pressure that lasts more than 2 weeks, because again, you might have bloating or pain or pressure for a day or two, it was ovulation. A couple of days before your period, it was cramping and bleeding. You're postmenopausal, and like I joke, if I drink too much wine or have pasta, I get bloated. But all of those things should be short-lived. They should last a day or two.
Okay.
Right? So if it lasts for 2 weeks, you should calmly say to yourself, this is likely not ovarian cancer. But if I don't have a really high index of suspicion and a low threshold to look and intervene, then I'm going to miss those few times where someone has ovarian cancer. And that means going to your doctor and saying, I'm having bloating, pain, or pressure. I'm sure it's likely nothing, but I need some kind of test. And typically the type of test we would first order is a pelvic ultrasound. It's not radiation. I can't say it's super easy to get done because not every doctor has it in their office. Sometimes they have to send you to a radiology department. When it comes to a high deductible, it's not necessarily covered because it's a diagnostic test. It's not a screening test. So there are pitfalls in it, but it's the best we have to offer right now.
Shieva, can I just ask, is it valuable to have a benchmark ultrasound done?
No, I mean, okay, so yes and no. No, because by definition, especially if you are premenopausal, our ovaries are changing day to day, week to week, month to month. So if I scanned anyone who is not yet postmenopausal, I'm going to see their ovaries going to change literally every day. And I'll see cysts that are largely benign that are meant to be there as a result of ovulation and things like that. So there will be a lot of false positives, a lot of cost to the system, a lot of pain. Like think about the three of us. Like we're busy. I don't have time to be going back to the doctor all the time, right? So the general answer is no. Now, occasionally, it would have been nice to know that someone had a benign, solid-looking cyst that once we find it in the setting of pain, we have to be a little bit more anxious and worried. But again, that's a smaller group of people, right? It's like saying, should we all do these whole body MRIs where they just pick up on things? I mean, in individual cases, has that been shown to help occasionally? Someone got lucky? Yes. But in general, if we do it, we're adding anxiety, we're adding false positives, we're adding cost to the system. So I can't just say absolutely not. I can say the long answer is no, I wouldn't do it. It's a great question, actually. But so bloating or pain or pressure, assuming it's in your lower pelvis, I say that's separate from your upper abdomen because then that's a separate thing. But lower pelvis, bloating, pain, pressure, please, please, please go see your doctor. And I hate to ever go against clinicians, but if your clinician says to you, I just did an exam, I don't feel anything, please say to them, I understand that, but I've also learned that a physical exam in this regard is just actually not so accurate. So could we order a pelvic ultrasound? Now, what it requires is for you as the patient to understand that the doctor cannot code the pelvic ultrasound as a screening test to get you out of paying for it. And one of the reasons clinicians probably don't readily order the pelvic ultrasound is they know that the patient is going to have to potentially pay for it if they have a high deductible. And the number of phone calls we get from angry patients pissed at us when we did not define what is covered and what is not.
Boy, that's a big topic in itself.
It's a big topic. That's why I always say, like, it's not easy to educate on this unless people understand the whole picture. Again, first, understand that you're not screened. Second, understand what your symptoms are. Third, understand what tests we can do, but also understand that we did not create the system as doctors. We hate the system. You need to unfortunately have some agency and responsibility in it. And that's not easy. I get it. People don't always have the resources. They don't have the time. They don't have the knowledge. They don't always have a clinician who has the time to explain all this. So it requires a lot, but all is not lost. If we keep talking about it and having people hear it, at least in these venues, then we can actually increase the number of people who are found at stage 1 or 2, where it is much more curable. And the treatment is still grueling, but less so than stage 3 or 4.
Well, so that takes us back to, so your story in terms of they diagnosed it because they found it through the endometriosis.
Mm-hmm.
You biopsied it, it was cancer. And then what was your journey going forward from that in terms of treatment?
Well, and so I initially, remember I told you initially the first diagnosis in the operating room, when they send the ovary, the first blush look is not always the most accurate, but it's to inform the surgeon you have to do more. So she found out that this was considered borderline, meaning almost cancer. And so she did a full staging. She removed my uterus, both of my ovaries, my everything, right? Including lymph nodes, which is the proper treatment. It turns out a week later, we found out it was actually what's called invasive cancer. That doesn't mean it's metastatic, but just invasive. And it was stage 2. So I was so grateful that I was with a GYN oncology surgeon and not a general OB-GYN, which again, we could talk
That's
about that
another
for
really
a
good
while.
piece of information.
And so within that week, even surgeons like me, even with surgeons like my surgeon who was amazing. I mean, again, so well trained, so empathetic, so good. There are still possibilities of complications. And I talk about that openly, not to ever blame my surgeon, but to say, even with me who knows better, and even with my surgeon who's amazing, our pelvis is a hard place. And I'd had previous surgeries. And so we found out within that week, not only that it was cancer and I need chemo, but my bladder had a small hole in it that then created a bigger hole. So I needed a second surgery to fix the hole in my bladder.
It was the hole created in the first surgery.
In the first surgery. And it was initially very small and then it kind of blew open. So I had to go back for a bigger surgery, believe it or not, have that repaired. And then I started chemotherapy. And the chemotherapy weakens your immune system and your healing. And so my surgical incision actually opened up and I needed to have a wound vacuum, literally this amazing device, whoever developed it is brilliant, to kind of suction the wound back together because you can't just sew it back up. So that process was also challenging and interesting and actually informed me so much of just what we do to ourselves as women. I had taken 6 weeks off to recover, but by this point, 6 weeks later, I'm like, oh, I'm going back to work. I'm going to be on call. So I go back to work on call in the middle of chemo with this wound vacuum that looks like you have to wear this little motor. I'm in the operating room one day and I'm thinking, this cannot be good for me. Why am I doing this? And my partners were so supportive. They were like, why are you doing this? But it just goes to show you as women, we feel like we should just plow through it. We can just, I can do it. It's fine. So luckily, I stopped taking call. I had a peaceful 6 months of chemotherapy, whereas I joke, I only saw 15 patients a day, which for me was part-time.
Oh my gosh, thank
And
goodness.
then I went to,
It's a lot of patience. And it's a good example of, as motivated as you are, for example, lots of women are, to take that break, take that pause. I mean, it's going to be steps to the process, perhaps, but also know when to dial it back and deal with it.
Yeah. Know when to hold them, know when to walk away, know when to run, right? Well, and I still laugh that all of us as women, even when we're scaling back, it's still, I joke, my chemo schedule was still 15 patients a day, which is bonkers that this is what doctors have to go through, right? So, but I had 6 cycles of chemo. It was not a walk in the park, and like anything, I had the privilege of being able to really see the beauty within the suck. I always say, it really sucked. The wound opening was painful. It was gross.
I love that phrase,
all shades
see
of everything.
the beauty in the suck.
Yeah, beauty within the suck. Because I feel and you know what I say a lot is, to me, saying things like, things happen for a reason, or look at the bright side, or look for the silver lining, smack of toxic positivity and demeaning what someone goes through. So I will never use those terms because they're already fraught with so much don't complain. I say to my patients and my kids all the time, I want you to complain. I am here for you to complain too, while us also being able to find the beauty within the suck. For me, thank God, I was a doctor. So I'm used to the hospital. I'm not freaked out walking to the hospital. These were my nurses, my oncologists, the people I knew. I have friends and family who are able to help me. A lot of people are not so resourced. Even if they have more money than I have, they don't have friends or family, or they don't have money. They don't have someone to take them. So to not be able to value that seems silly. So I think each of us can find something within the shitty part while also allowing ourselves to complain. I would never advocate for could be worse, don't complain. I'm oh no, I'm going to fucking complain. And I'm going to also remind myself where the good parts are, because there usually is something good even in the shitty.
Well, you got to kind of download on the problem before you can come up with the various solutions.
Yeah. Oh my gosh, Kristin, I'm sure you have millions of moments of this, right?
I can relate, and I'm sure many listeners too.
Yeah.
Really, such valuable insight.
Such valuable insight.
The beauty in the suck.
The beauty in the suck is so awesome. I love that.
The suck. Yep.
What was it like to be a surgeon, a doctor, sort of seeing everything from that lens?
Yeah.
It must have been a little nuts and crazy, although you know too much, but here you are.
I know. I mean, I always joke, like every time, I joke that like that was the end of my health journey, which of course it wasn't. It was 9 years ago, and I'm only 55. I got 40 more years on this earth, I hope. So I got many more
Looking
health
good,
journeys to go
girl.
through. But
2000
at
Mondays.
the time, thank you. 2000 Mondays. I used to joke that like every time something would happen, like I'd have yet another miscarriage or like my deliveries really were, challenging, all the things that happened, I'd be like, okay, God, this is just your way of helping me relate to my patients. Like, being able to say like, listen, I had HPV and I get it. It sucks. Not in a like, I got it, no big deal, but in a like, I get it. It sucks. I've had miscarriages. Like I kept going through things and I joke like, okay, God. And then with the ovarian cancer, I was like, just for the record, God, like I fucking empathize. Like you don't
Right.
need
I
to
didn't
keep
need this
showing
time.
me. Like I
That's
got this. Like
I now
I
get
don't
it.
need to go
Thank
through
you very
everything.
much.
Like I understand. But yeah, it's very eye-opening. I mean, the truth is like one of the biggest things that I hope I don't do to women. I mean, the concrete biggest thing I hope I don't do, besides I hope I don't dismiss or not listen. When women go through cancer, regardless of the cancer, but certainly breast or GYN cancers, which affect your ovaries by definition and then affect your sexuality and affect your tissue and everything, I hope I don't ever just leave it at that. I hope I always preemptively address those things because those things weren't addressed through no fault of, again, my oncology surgeon, my oncologist, the team. Your oncology team needs to keep you alive. And so the hard and sad part is that the whole mantle is being pushed on them. They're supposed to be the ones to also be like, hey, you got to keep you alive, but also like, how are you doing emotionally? Are you okay? Do you feel like having sex? Like, is your tissue dry? Like, what's going on? They can't do that all. So we have to do better as general gynecologists. We have to do better as primary care physicians. We need to do better as clinicians in general. And the hospital systems need to do better at having some kind of treatment, like a multimodal treatment where, and some of the big centers do this, but even the big centers don't do it very well often, where they literally have a separate team, separate from your oncologist, who is literally trying to keep people alive. You need a team of people who are addressing these facts with men and women, right? Because it affects them. I mean, it really, your life radically changes. And I saw how much that wasn't done. And I was luckily like, listen, I'm kind of like, I'm tough. I've been through this. I can take care of myself. I don't need the hand holding. But I think a lot of patients really deserve the hand holding. And
I think the patient advocacy part is instrumental too, because as much as we look to our professionals and cannot do it without our professional team, but really, if you've gone here to a doctor and then you've gone to this specialist and you have these diagnostics or these tests, really the center point is the patient. And so these points of awareness, you going out and speaking and having a voice, awareness months like we're talking about right now during ovarian cancer month, these are really important, even if the topic itself doesn't relate directly to you or a family member or a friend. It's just general patient awareness.
Right. Well, and I think what's really hard and sad for us as clinicians right now is that coming out of COVID, coming out of like, let's face it, decades and centuries of patriarchal medicine. So we have like the patriarchy that did a lot of bad things to patients and women in particular. And I'd love the advocacy to not necessarily be like in contention. Like, I need to go in there and advocate because they're trying to harm me. Your oncologists are not trying to harm you. They're trying to save you. They have a singular focus. Sometimes it's a little too singular focused. I wish they would look at you as a whole person, but the system doesn't really allow for that. So I just wish that it was like all of it could be done with better grace. Again, not just for the doctor's defense, but so that the patients could get better care and feel better about why things are happening, right?
I've been through a few medical things. My kids have had a few medical things, nothing as serious as what we're talking about here. But I do think ultimately there is an element you have to be your own advocate. And for something like ovarian cancer, if you're nervous about it or you're feeling as though maybe some symptoms are there, like you're saying, maybe have a nice conversation with your doctor. I'm anxious. I have had these symptoms. Can we find a way to just kind of get an ultrasound to be sure? There's probably ways of navigating it, like you're saying, that doesn't sort of create the anger because everybody's up against the system, whether it's doctors, we with the insurance issues that people have. So I think that's a great piece of advice. I think being your own advocate, small or big issues for yourself, for your family, is really what it's come down to. You sort of need to operate in that way.
And can I add to that? I'm sorry, just coming together as a community. I mean, Shieva and I share a good friend who has been in this situation and has really decided to be very upfront about her journey as well. So people like this woman and you, Shieva, being upfront just helps.
Right.
It helps the person to what do you want to say?
Unburden,
Thank
maybe?
you. Yeah, just kind of download, but it also helps the people who are receiving the message.
Yes. Well, and that
once
goes
you
back to
normalize
when,
it and
yes,
you talk about it,
talk
then
about it.
there could be
Well,
somebody else that hears through a friend and she's struggling in silence.
right.
And so the whole community aspect is huge. Talking to you is huge because maybe somebody who's having some bloating and some pressure didn't even think about going to
Didn't
the
know,
doctor. And
right?
even if they're fine, they went and they know they're fine.
Yes.
And maybe somebody went and it was stage 2 instead of stage
Exactly.
4.
Well, that's such a good point. What I was going to say is what we really need women to also understand is that let's say they have bloating, they go to the doctor, they get their pelvic ultrasound. Annoyingly, they have to pay $300, $400, $600, whatever it is. It's very frustrating. And then everything's normal. What I don't want women to then think is, oh, see, that was a waste. Because remember I said you have to have a high index of suspicion and a low threshold to look, knowing that the majority of time it's going to be nothing. If we don't approach it that way, then we're essentially just doing what a lot of doctors end up doing through no fault of their own, but they end up hedging their bets. Okay.
Can you say that one more time? A high
index of suspicion, I always say, like, I'm really suspicious that it could be something, even though I don't think it is anything, but meaning I have to always be thinking bloating, pain, and pressure could be ovarian cancer. I don't really think it is ovarian cancer, but if I don't always have that index of suspicion, I'll miss a few times, right? It's like, listen, this is an example I use. You hear something at your door in the middle of the night. You shouldn't assume, oh my God, someone's trying to kill me. This is going to be horrible. But you shouldn't be like, I'm sure it's nothing. It's kind of in between. I have to think it could be someone, right? So I have to have a high index of suspicion and a low threshold to kind of go investigate and figure it out. But I have to somehow do it in a calm manner, which indicates that I'm not freaking out, because freaking out is never going to help us. Because the problem with my kind of paradigm is go see your clinician, get your ultrasound. It's probably going to be nothing. Then women get a little bit of fatigue. Like, well, if it was nothing, why do I keep going back? But the answer is because 10 times it might be nothing, but the 11th time it might be something.
Listeners, please listen to that message, if nothing else.
I have a very good friend whose mom passed away of ovarian cancer relatively young. And I
Yes.
think it was sort of something that weighed on her, obviously. And she eventually ended up having a hysterectomy. I don't really know the details in terms of if there was testing, but I think that was just something because of the history that she chose to do. Can you speak
Yes.
to that a little bit?
Yes.
Is that something that...
It's a great question, really important. Okay, so besides, like I'm going to keep repeating, besides knowing what you're not screened for and besides knowing the signs and symptoms, every person should know their family history. And to me, family history, when I ask a patient, tell me your family history of cancer, I will often get the like, oh no, nothing. There's no history. So I don't just ask that. I say, mom, dad, aunts, uncles, grandparents, cousins, siblings, tell me, is there breast, colon, ovarian, uterine, melanoma, pancreatic, prostate, or GI cancers? Because those are the cancers that if they're in your family, they might increase your chance of getting cancer, either because you inherited a single gene, and some of those genes can be detected through blood tests, through genetic counselors, or there might be a multifactorial reason that doesn't carry a single gene, but then we know we're at increased risk. So any woman who has a first-degree relative with ovarian cancer, meaning her parent, her child, or her sibling, or even a second-degree relative, meaning a grandparent or an aunt or a cousin, really, really deserves to, first of all, consider genetic testing if the patient themselves didn't get genetic testing, and should have this discussion even more so than the general population about signs and symptoms, and deserves to know that they can do a risk-reducing surgery by removing their ovaries. And it depends on their age. We don't necessarily want to take out someone's ovaries premenopausally without a significant belief that we're going to decrease their risk. So discussion of that really should be something with your gynecologist or with a GYN oncology surgeon, because depending on your age, your risk factors, things like that, you can have your ovaries removed. And actually, another thing that millions of women don't know about, when women are going to have, for example, a C-section, if they are done with childbearing, they know they're done. As I joke with women, 1,000%, you never want to have another baby. If you have your tubes removed at the time of that C-section, you have significantly reduced your risk of ovarian cancer, because we now know that ovarian cancer actually it originates in the tubes.
Wait,
So
that's
Wow, that is fascinating.
It's
Wow.
fascinating, right? There
That's
actually just
fascinating.
this week, another data point was published at the number of women whose ovarian cancer might have been avoided had they had the risk reducing, the term is salpingectomy, which is a fancy term for meaning we remove your tubes, not your ovaries. at the time of either a C-section or any other procedure.
Love that
Love that too.
I tend to jump to paranoia and
Right.
fear.
And remember, right.
Yeah.
It's not only not helpful, but again, you're invoking a lot. You're like releasing a lot of cortisol. And to a degree, you're either going to avoid things by being so paranoid, or you're going to go into it with the paradigm of like, as I always say, like abnormal mammogram equals cancer equals death, which is just not true. Right?
Yeah, exactly. Now, quick question. So, does a male cancer like prostate cancer, is that
Yes.
actually a risk? Because now I'm sitting here thinking about it. My dad had prostate cancer, his dad's 3 or 4 brothers. And I always
Okay.
thought, oh, I should make sure my boys are checked early because I have a couple of sons. But maybe it actually is something that a woman
Yes.
should be concerned about. In what way?
Excellent question. So prostate cancer is one of those cancers that's incredibly common. And if every man lives till like 99 and then had a biopsy, and women as well, by the way, if we had a biopsy of our thyroid, our breast, and then men had thyroid and prostate cancer, there's some thought that most of us will have cancer cells in those organs if we live into our mid to late 90s, right? So
Because my
part of
dad
it-
was in his 40s, early 50s. So he was
Okay.
young for
Yes.
prostate cancer.
So the times that we are a little bit more alerted to a family history that could confer a genetic risk, either a gene that you can find or just a multifactorial genetic risk, is when someone is young with prostate cancer. Some of those genes are the ones that actually increase the risk of breast cancer.
Wow.
And so it would matter not only for you, but also for your boys and your girls.
And my daughters, yeah.
So I'm grateful for platforms like this because I think this is how we can get the word out.
Yes, exactly. And again, thank you for being here during this month of ovarian cancer awareness.
I personally have learned so much from all of this fascinating, interesting information. I knew some things, but I definitely have taken away a few amazing nuggets. I just have one quick question for you, and it's not related to ovarian cancer. If you had one piece of advice right now, right here, after this conversation to share with the world, and it could be anything, what would it be?
Okay. I don't know if I told you guys about my bracelet, my embrace the suck and move the fuck on. So I have these rubber bracelets that I had made pretty quickly after I got diagnosed. And listen, I love that you think I'm so optimistic. I am an optimist. I think I was probably born a little bit of an optimist, and then I've honed the practice a lot through a lot of like mental math and mental modeling of like, okay, well, the odds of me getting cancer are pretty high, but like the odds of me surviving it are also pretty high. So like, why am I going to freak out? And that doesn't mean I don't get anxious and nervous and worried and all those things.
Well, this was amazing. Thank you so
Thanks,
much for
ladies.
joining. And we ended on
Thank
such
you.
a high note. I am going to focus on that, and we are going to get ourselves a bracelet. We know that there are literally a million podcasts out there, and so many of them are so, so good. We'd love for you to tell your friends, daughters, and all the women in your life to tune in, get real, and share all the things.
Yes, share your stories with us by DMing and following us on Instagram at Gals Get Real Pod. And please subscribe, like, and share wherever you get your podcasts.
Until next time, lots of love.
This podcast is part of the Sound Advice FM network. Sound Advice FM, women's voices amplified.